from Dr. Salmaan Keshavjee on the treatment of MDR-TB and XDR-TB patients, selection and regimen design. It gives me a great pleasure to introduce you to Dr. Keshavjee. He's the director of the Program on Infection Disease and Social Change and also associate professor of Global Health and Social Medicine at Harvard Medical School. He has worked extensively with PIH drug-resistant tuberculosis program in Russia since 2000, and from 2006 to 2008, he was deputy country director of PIH Lesotho initiative, launching one of the first community-based treatment programs for MDR-TB and HIV co-infection in sub-Saharan Africa. Since 2005, and starting 2005, Dr. Keshavjee has represented PIH and Harvard on the Green Light Committee, GLC, for MDR-TB, the principal global mechanism for MDR-TB treatment expansion, hosted at the Stop TB Partnership and the WHO. From 2007 to September 2010, he served as a committee chair. Through his role at Harvard PIH and GLC, he has advised numerous national programs on clinical and programmatic management of MDR-TB. So now, I would like to give the floor to Salmaan.
Thank you, Alex, for the kind introduction. Hello, everyone. Thank you for joining us today, and thank you for joining me for this lecture. I will actually turn off my video, and you'll only hear audio so that the quality is better for people who are coming in from other places. So I'm going to turn it off now. So today we're going to discuss treatment of MDR-TB, XDR-TB, and I want to focus on two specific areas, namely patient selection and regimen design. I'm going to the lecture is organized around a number of papers that are accessible to you over the internet, or if you want to get them from the actual journals. This lecture will be downloadable later from the website, from this website, and so you'll be able to access any of the slides, and one of these slides is the recommended readings. So if you want to have further depth on these topics, I would recommend looking at these papers by Pepe Caminero and his team, Joya Mukherjee and her team, and then the World Health Organization's emergency update from 2008, which is actually a very detailed and important guideline on the treatment of drug-resistant tuberculosis. I've organized the lecture into three areas. One is who should be treated, and I'm going to talk about that briefly. Two is designing an effective treatment regimen for MDR-TB. How do we design it, and why have we chosen certain drugs? And then the third is designing an effective treatment regimen for XDR-TB. So let's start with who should be treated. So if you think of it, the ideal standard of care, if in an ideal world, would be to have all patients have their sputum sent for culture and drug susceptibility testing, and all confirmed DR-TB patients treated according to their DST results. And basically anybody who's suspected of having drug-resistant TB, starting them on an empirical regimen that's reasonably strong till you get the best available information. Either your test results or just based on history, contact history, etc. And essentially that's what we do with almost every other bacteria. For those of you who practice medicine in hospitals, you know that if you're treating Staph aureus or some other bug, you actually decide whether it's community acquired, hospital acquired. You take the history of the patient, and then you actually decide whether you're going to give an empirical regimen until you find out what the strain is resistant to. So that would be an ideal world. Obviously, in many places we can't do that. And so if you think about it, what we've done is we've tried to ask ourselves, who are the patients most at risk of having MDR-TB or XDR-TB or other forms of drug resistance, and who are the patients that we should actually be testing? Now, here is a list that's been adapted from a paper by Ignacio Monedero and Pepe Caminero, and it looks at individuals it's got a table of individuals at risk for TB drug resistance. And as you can see, it's a long list, and I urge you to look at it at your leisure and think about how these all pertain to you. But I'm going to focus on 5 of them because I really want I want us to look at a little bit of the data to think of who are the highest risk groups for people with drug resistance that we should definitely be looking at. So the first is failure of retreatment regimens in chronic cases. So when you think about it, retreatment regimens are basically, the main retreatment regimen that's being used around the world is the WHO Category 2 treatment regimen. Some countries have other versions of them, Category 2B, in the former Soviet countries, etc. But if you look at it, the hold on, let me pick up the. If you look at it, here's some data from Brazil, Peru, and Nicaragua. And if you look at it, you see that the percentage of MDR-TB in the failures of Category 2 is 65%, 87%, and 89% respectively. And you can see that in the data from Peru, it's actually a very large patient population. So for patients who fail Category 2, they're a very high risk group for MDR-TB. Exposure to a known drug-resistant TB case. We often have patients who have a family member or somebody else that, a close contact who has MDR-TB, and the question is often asked, do we actually start these people on MDR-TB treatment? Should we actually manage them as if they're an MDR-TB patient? Well, again, let's look at the data. If you look at data from Brazil, South Africa, other data from Brazil and South Africa and Peru, again, a large number of contacts being examined, you actually see that the percentage of patients with MDR-TB, if there is a contact with MDR-TB, so the percentage of patients with MDR-TB in that, related to their contacts is 62% in Brazil, 83% in South Africa, 83% in Brazil, 75% again in South Africa, and 84% in Peru. So the chances of somebody actually having MDR-TB, if they have a close MDR-TB contact, are extremely high, and these patients should be checked. People who fail Category 1. So if I've told you that people who fail Category 2 have a high risk of MDR-TB, conceivably you would say, well, maybe they had it at the end of Category 1. Well, it turns out that failures of Category 1 are patients who are still are generally thought of as being patients who are sputum smear positive at 5 months or later during the course of their treatment. And again, if you look at the data, these are data from Brazil. Failures of Category 1, 1/3 of them have MDR-TB. In Thailand, 86% of the patients have MDR-TB, and they have a high proportion of people who are HIV positive in this cohort. And these are data from Peru where they actually said, okay, maybe waiting 5 months is too long. Let's look at patients who are, at 2 months. Like, what if you haven't actually converted at the end of 2 months? And it turns out that if you actually haven't converted at 2 months, you actually end up with MDR-TB. I'm sorry, I jumped that. That's this paper right here. So you can see smear positivity at 2 months of therapy was strongly associated with failure. And the odds ratio is 11.7%. So it's not just a small association, it's actually a big association. And then the obvious is residence in areas with high drug-resistant TB prevalence. And I'm going to take a very stark example. And here's the example of Minsk in Belarus, where multi-drug resistant TB is found in 35.3% of new patients. So 1/3 of new patients. So again, you can imagine that's a scenario where you want to screen people. So in general, the key recommendations are that patients at risk of DR-TB should be screened for drug resistance. In people living with HIV, when possible, DST should be performed to avoid the mortality due to unrecognized drug resistance, and this should be done at the start of therapy. For initial screening of DR-TB, rapid DST methods should be used whenever possible because you want to get people on the correct regimen. And patients at increased risk of XDR-TB should be screened for resistance with the DST for isoniazid and rifampicin, which tells you if they have first-line resistance, and then the second-line injectable agents and a fluoroquinolone, because that will tell you if you have XDR-TB. So those are the key recommendations in thinking about who we should treat. Now we're going to have our first quiz. Let me read the question for the quiz, and you can check off the correct answer. What group of patients are at high risk for having drug-resistant tuberculosis and should be screened using either a rapid diagnostic test or mycobacterial culture? Answer A, individuals whose sputum smear has not converted from positive to negative at the end of the first month of treatment. Answer B, individuals whose sputum smear has not converted from positive to negative at the end of the 5th month of treatment. Individuals who have failed a retreatment regimen, for example, the WHO Category 2 treatment. Individuals who have been exposed to a known drug-resistant tuberculosis case. E, individuals with HIV or those that live in an area with high DR-TB prevalence. F is all of the above. G is answers B, C, and D only. And H is answers B, C, D, and E only. Okay, so the correct answer for this question is H. Answers B, C, D, and E only. So individuals whose sputum smear has not converted from positive to negative at the end of the first month of treatment. That answer, as far as we know, is not correct, because you give people a window of time to convert, and usually if people are responsive to first-line drugs, they convert between 2 and 6 or 7 weeks. And so most people feel that if you haven't converted by the end of the 2nd month or the beginning of the 3rd month, you're probably at risk of MDR-TB. And as we saw from that paper from Peru, they looked at people at the end of the 2nd month, and they found that there was a high risk, an odds ratio of around 11 of people having MDR-TB. But there are no data looking at people being negative at the end of the 1st month. So answer A, as far as we know, is not correct. Individuals whose sputum smear has not converted from positive to negative at the end of the 5th month, by the 5th month, you should have converted if you're going to be responsive to those medications. And so the data from different countries suggest that that is true. Individuals who have failed a retreatment regimen, as we saw, the data that I presented to you, and there's a lot more out there, if you have failed the WHO Category 2 treatment or other treatments, you tend to have a high risk of MDR-TB. If you've been exposed to a known DR-TB case, you have a high risk of MDR-TB. Individuals who have HIV should always be considered because they have a high risk of getting TB in general, and some suggestion that they have a high risk of getting DR-TB because of a variety of different issues, including absorption problems. And areas with high DR-TB prevalence, just statistically, you have a high chance of having DR-TB. Therefore, the correct answer is H. Answers B, C, D, and E only. Okay, let's go on with the presentation. Our next question is designing an effective treatment regimen for MDR-TB. So if we look at the drugs, the anti-TB drugs, we break them generally into 3 groups. The first is first-line drugs, and these are drugs obviously of known efficacy, thought to have a lower level of adverse events, and so these are the drugs that we generally use first. Second-line drugs are a group of drugs that we know have efficacy. However, other than the fluoroquinolones, they tend to cause a lot of adverse events, and so they were not chosen to be first-line drugs. The exceptions, of course, are the fluoroquinolones in that they are very efficacious, and this new drug, bedaquiline, which is known to be efficacious. And then the third group 3 drugs, third-line drugs, are the efficacy is questioned. Some people think they work. There are some data that show that they do work, but they're just not, their efficacy against Mycobacterium tuberculosis is not well characterized in vivo. So when you start to think about this, you see these 3 general areas, and then you actually see that there's 5 general groups: Group 1, Group 2, Group 3, Group 4, and Group 5. So a lot of people say, well, the current regimens for MDR-TB, they just came out of nowhere, and people haven't really studied them. And often people say that. That turns out not to be true. There's a great review by Joya Mukherjee, Michael Rich, Adrian Sochi, and their team looking at programs and principles in the treatment of multi-drug resistant tuberculosis. And it's in the Lancet in 2004. And basically, as you know, drug-resistant TB has been around since the beginning of tuberculosis. And as soon as rifampicin was used with INH, rifampicin alone, rifampicin with INH, we saw drug resistance. And so the problem of treating multi-drug resistant TB has really been around since the 1970s. And as it turns out, there are a number of studies in different places where people have actually looked at the treatment of MDR-TB and have tried a variety of therapies. And the therapies that they used in general were using the older drugs, what we now call second-line drugs, and as well as using new drugs. And Mukherjee et al. Looked at a number of different studies, and I'm not going to go through them. I urge you to look at this paper. It was one of the ones that I recommended at the beginning, but they basically go through all of these studies and they see what people have done. And through Mukherjee et al.'s analysis, which happened before the paper was published, through the outbreak in New York City where an MDR-TB epidemic was stemmed in the late 1980s and the early 90s, through the work of the National Jewish Medical Center in Denver, which really pushed the treatment of MDR-TB, work in Taiwan, other places, etc. Certain principles emerged. And those principles are what I'm referring to as the principles of MDR-TB regimen design. Now, Mukherjee et al. Argued that the best outcomes come from having at least 5 likely effective drugs. And what is an effective drug? It's a drug that usually the patient hasn't been exposed to previously. The general consensus in the world now is that you really should have a minimum of 4 effective drugs. And I'll go a little bit into that data and show you what the differences are. But let's just say that whatever regimen you're planning has to have a minimum of 4 effective drugs. You need to utilize parental therapy for a minimum of 6 months. So that's the injectable agent. Do not rely on drugs to which resistance is suspected or to which a patient has been previously exposed. So that's the key. Do not rely on drugs. So you can still use them because sometimes you think, well, the patient might be sensitive to it, and I'll explain why it might be useful to think that way. And we know that these first-line drugs are very effective, but you do not rely on them in your count of coming to 4 effective drugs. Include first-line drugs to which the infecting strain is susceptible, but do not count them if the patient has been previously exposed. Observe all doses, because you actually want to make sure that the patient gets the drug in their body. And this is one of the main things, is aggressively treat all side effects. Okay, this is very important because these medicines have a lot of adverse events, which I'm not going to go into in this talk because that'll be the subject of another talk. But if you don't treat the adverse events, it's impossible for the patients to take the medications. Okay, I told you that there's 5 groups. I'm going to go over them again, and then we're going to go through them. The first is the group 1 drugs, which are the oral first-line drugs. Group 2 is the injectable agents. Group 3, the fluoroquinolones. Group 4, the oral second-line agents with known efficacy against MTB. And group 5, the third-line agents active in vitro against Mycobacterium tuberculosis, but there's limited data on their in vivo activity. So the group 1 drugs, whenever possible, you should include first-line drugs. We know they're good. We know they work. We know they're tolerated. You should use maximum doses as much as you can. Occasionally, people use high-dose isoniazid, and I'm going to talk about that when we discuss the group 5 drugs, even though it is a first-line drug. And it may be used in cases of resistance at low concentrations, and we'll talk about that in a minute. In general, people do not count these drugs in the total number of effective drugs because if a patient has received a first-line regimen before, as many MDR patients have, you know that they've been actually exposed to all of them, even though you only know the resistance to isoniazid and rifampicin for certain. So we do not count these drugs as effective. Now, people often ask, should pyrazinamide be included? In a paper on MDR-TB that was done in the New England Journal of Medicine in 2003, Carol Mitnick and her group, looking at MDR-TB treatment in Lima, Peru, concluded that the inclusion of pyrazinamide and ethambutol in the regimen, when susceptibility was confirmed, was associated with a favorable outcome. Pyrazinamide, it turns out, may work synergistically with ethionamide and cycloserine in ways that we're not sure of, and there's now the suggestion that whether you know the resistance or not, you should include pyrazinamide, because pyrazinamide independently seems to be associated with a good outcome. So a lot of people include pyrazinamide throughout the treatment, but do not count it as an effective drug. Then the injectable agents. Usually people are resistant to streptomycin. And the second line injectable agents that are used for the treatment of MDR-TB tend to be capreomycin, amikacin, kanamycin, amikacin, and capreomycin, which is a polypeptide but works like an aminoglycoside. For all of you that just as a refresher, aminoglycosides bind irreversibly to the 30S ribosomal subunit. So what they're doing is they're interrupting protein synthesis in the cell. And they're bactericidal, and they should really be included whenever possible and given at the maximum doses that the patient can tolerate. Usually they're dosed according to the patient's weight. And sometimes they're dosed according to renal clearance. Ideally, patients take the injectable agent until the culture is negative for 6 consecutive months. Some guidelines suggest that the injectable agent should be taken for 6 months in total. Now, when you think about the injectable agent, we tend not to use streptomycin because isolates that acquire resistance to streptomycin are usually when you've taken first-line drugs or you've done category 2, you're resistant to streptomycin. In some countries, MDR-TB strains, whether the patient has been exposed to category 2 or not, tend to be resistant to streptomycin. For example, in a place like Russia. However, the good news is that strains that are resistant to streptomycin tend to be susceptible to kanamycin, amikacin, and capreomycin. Okay, so that's good news. Now, which one do you use first? It turns out that strains that acquire resistance to kanamycin show different levels of cross-resistance with amikacin and capreomycin. So, they often are not resistant to capreomycin, and they often are resistant to amikacin because amikacin is actually the synthetic analog of kanamycin. It turns out that strains that acquire resistance to amikacin always seem to have resistance to kanamycin and capreomycin. So that would suggest that you don't really want to use amikacin first because basically it results, if something goes wrong, it results in resistance to both kanamycin and capreomycin. And then isolates that acquire resistance to capreomycin are usually susceptible to kanamycin and amikacin. And this is all being described in the literature. Now, my colleague, Dr. Pepe Caminero from the International Union, he's really, he's thought about this a lot. He's written one of the articles that I've recommended to you. And he says, well, the logical sequence is, based on what we know about the way that resistance develops, is that you would use capreomycin first in everybody, then kanamycin, and last you would use amikacin. That's not what we do. That's the logical sequence. But what we tend to do, and it's really linked to availability and price, is we tend to use kanamycin or amikacin first, and then capreomycin. The reason that happens mostly because of price and availability. But there's some medical considerations to think about. Sometimes we use capreomycin in a patient first because they're diabetic, or because capreomycin is thought to be less nephrotoxic and ototoxic, and there's a reason to use that. Sometimes we use kanamycin and amikacin because it's thought to cause less electrolyte disturbances. So, you sometimes make the decision not, just based on the patient characteristic as well. Okay, then the fluoroquinolone. So fluoroquinolones are highly bactericidal second-line drugs. They're thought to be the backbone of the second-line regimen. They should be included in every regimen. The cross-resistance between fluoroquinolones is thought not to be complete. And they should not be given intermittently because of their pharmacodynamic properties and the pharmacokinetic properties. They should not be given intermittently. They actually need to be given daily. Now let me go into a small refresher course on remembering the fluoroquinolones and then thinking about how we think about which one is better. So you guys will remember there's second generation, third generation, and fourth generation fluoroquinolones. The second generation fluoroquinolones are ciprofloxacin, some parts of the former Soviet world, lomifloxacin and ofloxacin. Third generation are levofloxacin, and a drug that's being removed from the market, sparfloxacin. And then fourth generation are moxifloxacin and gatifloxacin. Sparfloxacin has been removed from the worldwide market. Gatifloxacin has been removed from most markets, most notably in North America and Europe. We don't use ciprofloxacin and lomifloxacin ideally because they're second generation and they're actually thought to have low efficacy against Mycobacterium tuberculosis. So generally, these are not ideal to use. Now, the fluoroquinolones bind to DNA gyrase and topoisomerase 4. These are two parts that are involved in the replication of bacterial DNA. So fluoroquinolones bind to either of these complexes at these spots here that are marked Q, and that depends on the property of the fluoroquinolones. And newer fluoroquinolones act against both of these spots and are less affected by dual mutations than older fluoroquinolones. So that's something to remember. Now, when we think about whether a drug is good or bad, drugs have different qualities. It turns out that for fluoroquinolones, you really have to think about they actually work by concentration and prolonged persistent effects. So there's certain pharmacokinetic and pharmacodynamic properties that we need to look at to see if a fluoroquinolone works. You guys will all remember, whenever we talk about a drug and its ability to work, we think about the minimum inhibitory concentration, the MIC. And that measures an antibiotic's activity. And it's usually thought to be the lowest concentration of an antibiotic that inhibits the growth of the microorganism. And it's really an indicator of potency. For an antibiotic efficacy, we have to think about peak serum levels and this area under the curve, the area under the serum concentration curve. So when you put together these properties, the pharmacokinetic and the pharmacodynamic properties, and I'm not going to go into them because this is a lecture in and of itself, but for fluoroquinolones, you really want to make sure that they have a high concentration. They're very much above the MIC, and that they have what's called a prolonged persistent effect. That is, that they're above the mean inhibitory concentration for a long time. So here's the mean inhibitory concentration, and you want them to be above the mean inhibitory concentration for a long time. And that's the prolonged persistent effect. And the measure of that, of those two variables, are Cmax over MIC and 24-hour area under the curve over MIC. So those are the two measures. I don't want to go too much into detail. I just want to give you enough so that we can see which fluoroquinolone is better. And the one that's got a bigger 24-hour AUC over MIC is above the MIC for a longer time. So that makes it in some ways better. So if you look at the fluoroquinolones, when initially people were looking at comparing moxifloxacin, gatifloxacin, and levofloxacin at 500 milligrams, because that was the dose of levofloxacin people used to use, it turned out that moxifloxacin and gatifloxacin had the best sterilizing activity. They had the best AUC 24 over MIC, and levo was about half of moxi. Then when you started looking at it more in depth and the dose of levo was ramped up, and in North America for pneumonia, for example, we use 750 milligrams of levofloxacin, you see that the Cmax over MIC starts to match that of gatifloxacin, okay, which is very good. And when you compare high-dose levofloxacin, so 1,000 milligrams of levofloxacin daily with 400 milligrams of moxi and 400 milligrams of gatifloxacin, you start to see something really interesting. This dotted line here is isoniazid, and these solid lines are levo, moxi, and gati. And you start to see that high-dose levo, 1,000 milligrams, which is considered safe in most people, actually starts to look a lot like moxi and gati. And when you look at the pharmacokinetic and pharmacodynamic parameters after 5 days of daily monotherapy with the drug, you start to see that the AUC over MIC for levofloxacin is actually a little bit better than moxi and gati. So it actually stays above the MIC for a longer period. So that suggests that it has some slightly beneficial qualities. And then when when you look at the pharmacokinetics of levo, gadi, and moxi, you find something really interesting. If you give 1,000 milligrams of levo, again an amount considered safe, levofloxacin produced the highest maximum plasma concentrations, the largest volume of distribution, and the longest eliminational half-life. So it's there for a long time above the MIC. So it's got the most favorable results are seen with levo. Interestingly, high dose, not low dose. Important distinction. Now, some people say, well, should I use levofloxacin or ofloxacin? Levofloxacin is the L isomer of ofloxacin. So it's basically, ofloxacin is a mix of two isomers of the drug, the L isomer and the R isomer. And levofloxacin is the L isomer that's been isolated. Well, it turns out that the L isomer binds better and differently. So when you compare levofloxacin to ofloxacin, as this study in CHEST in 2003 did, you can see that overall levo does better than ofloxacin, and this isn't even high dose. This is just 500 milligrams. And you see ofloxacin susceptible strains, you have a 96% efficacy in the levofloxacin group, and in ofloxacin resistant strains, you have almost an 80% efficacy, whereas with ofloxacin resistance, you see 45%. So you really see a big difference. And I think we should be using levo and high-dose levo. You'll make the decision to use moxi for other reasons. Moxi is cleared by the liver, so somebody who has kidney failure, you won't use moxifloxacin. There are other medical considerations to using moxifloxacin over levo. But in general, high-dose levofloxacin is a good drug. Now let's look at the second-line drugs. Ethionamide has got bactericidal properties. It inhibits mycolic acid, and its target is a gene called INHA. Resistance occurs rapidly if it's used alone. There's another resistance gene that's called ETHA, which activates the drug. So it's a good drug. There's complete cross-resistance between ethionamide and prothionamide, which are the two thioamides that are used for TB. It's generally well tolerated. It causes gastric upset, so you have to actually manage that side effect. Cycloserine is bacteriostatic. It blocks the enzymes that incorporate alanine into the cell wall. It does not exhibit cross-resistance with anything. Causes psychiatric adverse events in some patients, but it's generally well tolerated. And you've often heard people talk about taurizidone, which is actually a dimer of cycloserine, but there are very few studies on that. Para-aminosalicylic acid, people aren't really clear how it works, but it's a very old drug. It's thought to inhibit folic acid synthesis, the synthesis of mycobactin, which is a cell wall component, the inhibition of nuclear factor kappa B, and free radical scavenging. So it may work through multiple mechanisms. It causes gastrointestinal upset and has done that for years and years everywhere. So it's definitely something that we should use, but you need to look after adverse events. Bedaquiline, which is a new drug that was just approved by the United States FDA. It's known as Sirturo as its brand name. It basically, if you look at this curve, looking at time to culture conversion as a proxy for cure, you can see that bedaquiline cuts the time to culture conversion significantly, by 40% or so. And so, it's a good drug. Its one adverse event is that it prolongs the QT interval. I think the manufacturer has recommended that it not be used with moxi for that reason, but it can be used with levaquin, and I think that they're generally recommending 750 milligrams of levaquin. Linezolid, we've often heard about linezolid. It causes a lot of adverse events, so people have been scared to use it. It causes all sorts of blood dyscrasias. It causes irreversible peripheral neuropathy, but it turns out it's very efficacious. And there's a paper that's been put out, an excellent paper by Giovanni Soccu and his team, and basically they argue that other than the adverse events, which you obviously have to monitor, and they list it here, and I urge you to go back to this slide, it's got good efficacy. Then there's the other drugs, the third-line drugs. These drugs, they have efficacy against MTB, but it's not well characterized in vivo. They may work synergistically with other drugs, and the rule of thumb has been to count them as half an active drug. So amoxicillin clavulanic acid, which works against the beta-lactamases that Mycobacterium tuberculosis has, it's found to have some bactericidal properties in vitro and some suggestion in vivo. Some early bactericidal activity suggests that it might even have in some characteristics similar to ofloxacin. So its role remains unclear. People do use it. Clofazimine has intracellular and extracellular antimycobacterial activity. It concentrates preferentially in macrophages, which is where the mycobacterium goes, and it's found to eliminate TB bacilli from mice, spleens, and livers. It's thought to have very similar bactericidal activity to amikacin in cultured human macrophages. And it's basically found to be effective. It's actually been used in a number of different regimens, most notably what people are referring to as the Bangladesh regimen, and it's been used in places for the treatment of XDR-TB like Peru, which have had very good outcomes. Carbapenems have been used to overcome beta-lactam resistance. The two most notable are imipenem and meropenem. They've been shown to have in vitro activity against MTB, and they have increased synergy with clavulanic acid. The problem is they have to be given with IV, and they've never been tested in a trial. Thiacetazone, old TB drug, it's bacteriostatic, it affects the cell wall. People tend not to use it because it's contraindicated in patients with HIV. It causes Stevens-Johnson syndrome. It's also contraindicated in some groups from East Asia where it has increased rates of Stevens-Johnson syndrome. Now, high-dose INH. A lot of people say, well, can we just use high-dose INH? Well, it depends. It depends on where the mutation is. There are two general mutations for INH, INH-A and CAT-G. The mutation of the INH-A gene promoter region, which is the target of ethionamide and prothionamide, often results in low-level resistance to IS&IAZ, but it does have resistance to ethionamide and prothionamide. So strains that are resistant to INH-A, you can use high-dose INH. Strains that are resistant to both low-dose and high-dose concentrations of INH usually have a CAT-G gene mutation, and basically these strains are sensitive to ethionamide and prothionamide, but not to high-dose INH. So you really need to know what genetics you're dealing with to know whether high-dose INH is going to be helpful or not. Another third-line drug is thioridazine, which is an antipsychotic that affects bacterial efflux pump inhibitors. It's been used in XDR-TB patients, most notably in India and in Argentina, and it's had some good effects. I've put the papers there so that you can read them. And clarithromycin, which is a drug that causes a lot of stomach upset, people have now determined that this is not an effective drug. So if you use these types of drugs for MDR-TB and you do it for 18 months, and if patients receive direct observed therapy, you generally get good results. Pool success rates of 69%. It turns out that individual regimens tend to have a higher success rate than standardized regimens, but of course that depends on the standardized regimen, and you can see that there's a wide confidence interval which makes this comparison statistically non-significant when you use the type of statistics being used. Okay. There's been a very important meta-analysis. I'm going to go 2 minutes over, unfortunately. There's been a meta-analysis that has looked at what leads to good outcomes. Later generation fluoroquinolones leads to it. The use of prothionamide or ethionamide leads to better outcomes. The use of 4 or more effective drugs, and the use in the intensive phase, and the use of 3 drugs in the continuation phase. This is a 200% improvement. So you have to think that these are actually very important things to look at. Our group in Peru looked at what if you used 5 drugs in patients, which is what Mukherjee et al. Had recommended for more than 18 months. And they found that if you do that, you are significantly less likely to die. The risk of death is reduced by 40%, and recurrent disease is reduced by 60% after you're cured. So very significant. Okay, quiz number 2. Oops. What approach to designing an MDR-TB regimen are likely to lead to positive treatment outcomes? A, inclusion of ethionamide or prothionamide. B, inclusion of 500 milligrams of ciprofloxacin twice daily in the treatment. C, inclusion of pyrizinamide in the treatment regimen. D, inclusion of high-dose levofloxacin or moxifloxacin in the regimen. E, optimizing the regimen by using 4 or more effective drugs in the intensive phase of treatment and treating patients for at least 18 months. F, all of the above. G, answers A, B, and E only. Or H, answers A, C, D, and E only. Okay, let's look at the answers. The correct answer, so let's go through them. Answer A, inclusion of ethionamide or prothymide. Yes, it's shown to actually give almost a 200% benefit. Inclusion of 6-rofloxacin. No, because ciprofloxacin actually has not been shown to be that efficacious against MTB. Inclusion of pyrazinamide in the regimen. Yes, it seems that pyrazinamide helps the regimen. Inclusion of high-dose levo or moxie. Yes. Optimizing the regimen by using 4 or more effective drugs for 18 months. Yes. All of the above, no, because of point B. G answers A, B, and E only. No, because the others, some of the others are true. So the correct answer is H. Answers A, C, D, and E only. You guys, I've run out of time, but I want to make one important point about XDR-TB treatment. If we could go back to the slides. Just really quickly, XDR-TB treatment is the same as MDR-TB treatment. You use the same principles from the 4 groups. One key thing to remember, always use the fluoroquinolone and the injectable drug in treatment. And I'm going to explain to you why. One is that I told you the fluoroquinolone, high-dose fluoroquinolones, high generation and high-dose levo can actually overcome resistance because they bind to different parts of the DNA gyrase complex. That's one. The second is there's a lot of data suggesting that there's mixed strains. So always use a fluoroquinolone because the strain that you see on the sample may not be the strain that's there, and you can look at these papers at your leisure. And if you do that, what we have found in Peru, we have a 60% cure rate for XDR-TB using clofazimine, and in Russia, a 48% cure rate not using clofazimine. So very, very good outcomes. I'm going to end there without doing quiz 3 and go to the questions. Okay, first question, should category 2 regimen be used at all? Is it a safe regimen to add just one drug, streptomycin? So if somebody is failing a regimen and you add one drug to a failing regimen, you're almost guaranteed to get resistance to that drug. And that may be why we see in patients who fail category 2 not only resistance to isoniazid and rifampicin, but almost universal resistance to streptomycin as well. The thinking behind category 2, and I don't think it's very sound thinking, but the thinking was, well, you can use a category 2 regimen, which is a reinforced regimen, in people who had defaulted from category 1. So they didn't take category 1, or they didn't take all of category 1, but they defaulted, they come back and you give them the category 2 regimen, which is reinforced. However, if you're just looking at failures of Cat 1, you definitely don't want to use category 2. There's a bunch of recent papers, most notably by Jennifer Fern, looking at the category 2 regimen's use in Georgia, and you can see that people, you really don't want to use category 2 in patients, especially without testing them for MDR-TB, because there's a high proportion of MDR-TB patients in the category 2 group. And I've listed some other papers earlier in this presentation from Brazil and other places. Want to know about any cross-resistance between rifampicin and INH? As a common statement is that expert RIF is a marker of MDR. Well, in many places, when you have RIF resistance, you have INH resistance. And that is why people think that if you can measure RIF resistance, it's a good marker for MDR-TB. That tends to be true in some settings. I'll give you the example of Russia. INH monoresistance is reasonably low. Rifampicin monoresistance is reasonably low. So when you end up having RIF resistance, you usually have MDR-TB. That being said, our group here at Harvard, led by Mercedes Becerra, is just putting out a paper on isoniazid monoresistance in children. And while they found many places without isoniazid monoresistance, in the places with isoniazid monoresistance, the monoresistance ranged from 8 to 27%, I believe. I don't have the paper in front of me. So there are places where, there is isoniazid monoresistance. And if you actually measure RIF resistance in that group, you would find no RIF resistance. And then you would give the patients, HREZ at the beginning, and the H wouldn't be effective. And you would give them R in the continuation phase, and you probably would end up getting some amplification of resistance. So it's definitely something to think about. Comment. In Kyrgyzstan, in our regimen, we suggest not to use amikacin, ofloxacin, ethio in the regimen due to high risk of resistance in the region. I don't fully understand that question, but I would say that if you have resistance to fluoroquinolones, you should probably be using high-dose levo or moxie. Generally, if you have resistance to amikacin, as I was showing you, statistically, you tend to have resistance to to caprimycin and kanamycin, but often people will still use an injectable agent. In that part of the world, probably caprimycin. And if you have resistance to ethio, you generally have resistance to ethio and prothionamide. Again, because of mixed strains and a few other things, a lot of people will still use ethio or prothionamide. Could you comment on the duration of injectables, 8 months, based on the WHO update in 2011? For example, especially in resource-limited settings, not able to culture that frequently or not at all, should they continue the injection until the culture result from the 8th month comes back? Well, this latest WHO update is based on a meta-analysis that was done looking at about 9,000 patients. And what was found was that if you have the injectable agent for longer, 6 months or longer, you tend to do better, and the optimum amount was 8 months. So if you think about the old recommendation, and that's the recommendation that I just went through in this lecture, I told you, well, it's better to do 6 months after culture conversion. On average, people culture convert from culture positive to culture negative at the 2-month mark. And so you do 6 months more, and that's roughly 8 months. And that's interesting because that's what the data seems to show. So I don't know how to answer your question because you really need to know whether the patient has culture converted or not. If you're not checking culture sufficiently, then you probably should be doing somewhere between 6 and 8 months of the injectable agent, 8 months preferably. Can we include patients with the history of DILI who has been treated with fluoroquinolone as TB, MDR-TB suspects, and do challenge and re-challenge procedure have a risk of developing DR-TB? I don't even know what DILI is in this thing. Can somebody just write that down in the chat screen, please? Okay, I'm going to go to the next question just because we only have 4 minutes left. I don't want to waste time. And Natalie, when you finished explaining that, I'm going to go, I'll come back to it. Whenever a patient is diagnosed, drug-induced liver injury. Well, great that you asked this question because we recently put a paper out on this. Can we include a patient with a history of drug-induced liver injury who has been treated with a fluoroquinolone as a TB MDR suspect and do challenge and re-challenge procedure has a risk of developing DR-TB? Okay, so you have to really basically identify what drug has caused the liver injury. And basically, we found that a lot of the time it was pyrazinamide. Of course, fluoroquinolones can use it, can cause it. Isoniazid, of course, can cause it. And so I'm assuming you're meeting a patient who's got regular TB. Should you create a modified treatment regimen for them? You can create a modified treatment regimen for them. You have to remember that if you take isoniazid out of the regimen and you replace it with a fluoroquinolone, and you do fluoroquinolone, isoniazid, fluoroquinolone, rifampicin, ethambutol, and you maybe drop pyrazinamide for some reason, then you have to add other drugs so that the patient has the equivalent of 4 effective drugs, and it lengthens the time of treatment. So most people, when they're dealing with first-line patients with DILI, will basically say, look, most likely it's pyrazinamide, and they'll re-challenge with INH, RIF, ethambutol, and 1 other drug. And if you have the RIF but you don't have the pyrazinamide, you usually have to go longer than 6 months because it's the pyrazinamide that helps lower from 12 and 9 months to 6 months. And usually people will go for 12 months of treatment. This is an area where there needs to be more research. Okay, whenever a patient is diagnosed with MDR-TB, there's a tendency to go with the maximum number of drugs possible, taking support from the statement that it's a minimum of 4 drugs. And I have seen patients on 7 drugs. Is that okay? What would be your recommendation? Well, it turns out that the Bangladesh regimen, which seems to be very successful, is 7 drugs in the intensive phase. And it seems to be very successful. And we have to ask ourselves, is it successful because it's putting 7 drugs up front in the intensive phase and is actually causing a very good killing of MDR-TB? We don't know the answer to that. There needs to be more research into that. But I would say that we saw 4 drugs being better, and we saw so we saw 4 drugs being better, and we saw that the study from Peru that just came out, that if you do 5 drugs, you actually reduce the risk of death, and you actually reduce the risk of recurrence. So my recommendation is that if a patient can tolerate more drugs, based on what we're seeing in Bangladesh and the data that we just saw from Peru about 5 drugs, I would say that it makes sense to use somewhere between 5 and 7 drugs at this point. Again, more research needs to be done on it, but this is what the data from the field is suggesting. Should we rely on RIF in patients who has got category 1 and category 2 in the past, but DST shows sensitivity at present? Well, that's a really interesting question, because if you've received category 1 and category 2 in the past, and you are resistant to other drugs, you really should be resistant to RIF. Some people have problems with RIF absorption, and as a result, you don't see RIF resistance. I would keep RIF in the regimen, but I would add other drugs to make sure that they have at least 4 effective drugs in the regimen. So RIF can be there, but you can't count it as an effective drug because they've actually been exposed to it for 6 months plus an additional 8 months. Can we use ciprofloxacin in general practice when as it has weak anti-MTB activity? It is actually widely used in general practice. Well, it seems that it's okay to use it in general practice. It's still got some anti-MTB activity. So, this is one of the problems of why fluoroquinolone resistance is increasing in many places, is because we're using fluoroquinolones for so many, other diseases. Now, in general, the studies from streptomycin in the old days in the 1960s showed that if you start to develop resistance usually after 2 weeks of using a drug, 2, 3, 4 weeks of using a drug. So 2 weeks onward, and certainly after 4 weeks. So if you're in a prolonged fluoroquinolone regimen for some reason in a part of the world that has high TB, or in a patient at high risk of TB, I would think that you should screen the patient for TB first before giving the fluoroquinolone, regardless of what fluoroquinolone it is. Is it possible to do DST for every client before initiation of major drug therapy? Well, it turns out that in the Western world, people do that, but the levels of TB are lower. In some parts of the world, like Russia, where you have high rates of TB, they do DST for every patient because they have laboratory capacity to do that. Many parts of the world don't have such laboratory capacity, and so the new recommendation is to use GeneXpert, where possible, to screen out patients who have RIF resistance as a potential marker for MDR-TB. Now, that test tends to be good in most parts of the world, so you can use it, and then the patient still has to go for a DST usually, because you want to find out if they have isoniazid resistance, and in some parts of the world, you really need to know if they have XDR-TB. So to answer that question, is it possible to do DST? Yes. Does the capacity exist everywhere? No. Should capacity be built to move in that direction, in the absence of better molecular tests that can tell us resistance to isoniazid, resistance to fluoroquinolones, resistance to injectable agents? It's something to definitely consider. For a child who develops TB from an MDR-TB patient, is it advisable to start second-line TB regimen? Yes. The data suggest that child contacts of MDR-TB patients have a very high rate of MDR-TB. And I would suggest that you read a paper by Mercedes Becerra, Becerra, and her team in The Lancet on this. Can you explain why WHO used to give INH for chronic type TB before we knew about MDR-TB? I'm sorry, I actually don't know the reason why people do that. I've seen that practice in many parts of the world, that people give INH. I know that in the case of the Russian Federation, people tend to use this kind of INH in chronic patients, or even sometimes give 1 or 2 or 3 first-line drugs, and I think they see it as a way of reducing a high burden of TB and death in patients who already have exhibited some resistance. Obviously, these patients do ultimately end up dying, so I don't really know how helpful that is. I think it gives patients hope, and it gives staff hope as well. Okay, we're at the end of the questions. We're at the end of the presentation. I really want to thank everyone for your participation in this and for letting me share this lecture with you. Thank you very much.
Thank you, Salman, very much for your interesting talk. I think everybody enjoyed that very much. We had very many, a lot of questions. Some questions were actually we are out of time right now, so that's why we don't have capacity to answer all questions. What I'm actually encouraging people to do is also go to the RTB website and look for a webinar we did last year in June, July. We have some presentations about side effect management, because I noticed that we have some questions about side effects. So you can download presentation, you can download audio, you can download video file, or look on your computer online and see the presentation. And also about pediatric questions, we're gonna have this year in June, July of this year, we're gonna have MDR-TB webinar on pediatric MDR-TB webinar. So for how to manage kids who are on contacts or sick actually with TB and MDR-TB. So Mercedes Becerra from Harvard Medical School going to organize this webinar course. It's going to be about 6 to 8 talks. Should be very interesting. So again, I would like to sincerely thank Dr. Keshavjee for very informative and interesting webinar. And I would like also to